Okay, so we'll be talking about medicine topics. It'll be very limited. So the first thing in medicine, we're going to learn about RTA, renal tubular acidosis. So, renal tubular acidosis, you must know that it is an example of normal anion gap metabolic acidosis. Now, if you see, how do you suspect a patient with renal tubular acidosis? So, first, they'll be having a low bicarb concentration. When you do an ABG, they'll have a low bicarb concentration. You do the ABG and then you check for the anion gap. The anion gap is normal. You suspect. If it's raised, you have a lot of examples like DKA, uremic disease, lactic acidosis, and also toxins like methylene glycol, salicylate poisoning, all these things. If it's normal, you have to check for the urinary anion gap. Now, this urinary anion gap can be positive or negative. Positive is when you see in RTA. Why is it positive? Because mostly in RTA, all the chloride ions are excreted. So obviously, you will have a positive value. Whereas in negative, both positive and the negative is being excreted. So when you have all the things excreted as diarrhea, GI, and pancreatic or biliary secretions. Okay, so I'm not going to talk about the topic, and I'm not going to tell the clinical features. So I'm going to tell the clinical features and then I'm going to go to the topic. That's how you understand. So for the clinical features, there are three types: type 1, 2, and 4. Third is mixed in on rare type. Now type 4 is the most common type. Okay, so first one, we'll talk about type 4 itself. Now type 4, how they may present as, see, a patient may have an history of DM or AIDS or tubulointerstitial connective tissue disorders or hypertension. Now, how will the patient present is that he will have metabolic acidosis, but also he might also present with any cardiac abnormalities because of the presence of high hyperkalemia. So the patient will have hyperkalemic, hyperchloremic metabolic acidosis. Now, why does this happen is because of aldosterone deficiency, resistance and aldosterone deficiency. Okay, so if you see he may also progress to CKD, because already a diabetic nephrotic patient, so he is already progressing to CKD. If you see for the blood pH, already it will be acidotic. The urine pH will be low or high. Now the bicarb will be normal, and PCO2, okay, citrate will be low, Fanconi syndrome. So it's an example of a hyporeninic hypoaldosteronism. So this is the early CKD, aldosterone resistance. You have a lot of arrhythmia in the patients, and then the urinary pH will be less than 5.5, and potassium will be more. Whatever it is, now how it is caused, it can also be caused due to drugs with ACE inhibitors, ARB, and all that. So you stop the drug and you have to give the potential cure. That is the easiest thing. Next, and also you should know it's an acquired form of RTA. So this is a diabetic patient with arrhythmias. Next patient will talk about type 1 and type 2. Now type 1 and type 2 both are salt wasting syndromes. So how the patient will present is that so since it is a salt wasting syndrome, he will already have acidosis, and he may present with stones. So you have stones, hypokalemia, and acidosis. So and and see how he will present: rickets, recurrent loin pain because of the stones. You'll have muscle fatigue, muscle cramps because of hypokalemia, and also recurrent loin pain, rickets. This type 1 RTA, why does it happen? It is because of there is an there's an abnormality in the hydrogen and ammonium chloride excretion. So everything gets accumulated within the system. So what happens is, since it's acidosis, aldosterone will be activated, and sodium will be absorbed, and potassium and hydrogen will be lost. So it's just more of metabolic acidosis. Now, it's more of metabolic acidosis, and it's an defect in the alpha intercalated cells of the DCT. That's why it's called as a distal RTA. Now, what are the causes? The patient may have because of before that, because of how does he get stones? Because of the acidosis, what will happen is a lot of calcium will be lost in urine due to bone resorption. This will cause hypercalciuria and can cause renal rickets. Hypercalciuria can also can cause nephrocalcinosis, which will also have hypocitrate urea because increased citrate utilization followed by intracellular acidosis. Now, what kind of stones you see is mostly you see calcium oxalate stones. Here you can also see calcium phosphate stones. The patient may also, if you go back to the history, you may also see um, a history of multiple myeloma, scleroderma, Sjogren's, primary biliary cirrhosis, SLE, hypergammaglobulinemia. Everything is present, and also drugs like amphotericin B toxicity can also cause primary renal tubular acidosis. Okay. Now the last one is secondary renal tubular. Type 1 renal tubular acidosis. Type 2 renal tubular acidosis is because of the defect in the PCT. Now PCT generally, you should know that PCT generally HCO3 is reabsorbed. Here HCO3 is not reabsorbed, which can lead to marble brain or marble bone disease, which will cause cerebral calcification, osteopetrosis, and all that stuff. Now this you should remember is how the patient will present. The patient will present with a Fanconi's triad. That is, there will be lots of acidosis. Again, you'll have lots of salt wasting syndrome. Hyperaldosteronism will be there. Decreased amino acids, decreased potassium, very less. Decreased glucose, phosphates will be less. And the most important thing is bicarbonate loss. He is in acidosis because H plus is accumulated and bicarbonate is lost here. So okay, so this is what happened, but what are the causes? What might be the causes is because it may be associated with Fanconi syndrome and also be associated with disorders like galactosemia, Wilson's disease, hereditary fructose intolerance, Loeys syndrome, oculocerebrorenal syndrome. He'll have cataract, glaucoma, hypotonia, etc. And multiple myeloma can also be there. Hyperparathyroidism, increased PTH, and also outdated tetracycline. There we use amphotericin B, here tetracycline, gentamicin, and all that, and also other tubulointerstitial diseases. Now the patient is going to come to us acidosis. When you do ABG, you will find that the bicarbonate is very less. That is the only significant thing that you can find here. And also he will have vitamin D activation defect. So he will also have osteomalacia, D3 deficiency, and all that. So treatment is mostly in all the three types you will give soda bicarbonate. Oral soda bicarbonate is a palliative thing. Here you can give thiazides because it's going to cause metabolic alkalosis. The thiazides is going to reduce the volume contraction. Already here the volume is contracted. Now going to reduce the volume contraction, GFR will be less, so RAS will be activated, aldosterone will be more, and so metabolic alkalosis will be present. Now one thing you have to remember is RAS activation does not have anything to do with hypertension. So you don't have to think about, aldosterone has nothing to do with hypertension. Aldosterone is basically sodium and water reabsorption and potassium and hydrogen ion excretion. So that is RTA.